So, this being the case, first an introduction, brief introduction about surgery as a profession. Surgery is a skill subject. It is a skill. It is a skill which involves eye, hand and hand-eye coordination, both of them being propelled by the intellect, intelligence, the knowledge of the surgeon, of the professional. Surgery is like carpentry, painting, shooting, cricket, any sport, any art, anything. Greater the exposure, greater the practice, greater the practice, greater the experience. Greater the experience, greater the efficiency. That's it. So, to give a small example, I'll give you two examples. A person joins a cricket coaching academy. Initially, he or she finds difficulty in facing the deliveries, or initially he or she finds difficulty in bowling the deliveries. Over a period of time, under the supervision from the coach, he or she develops the technique of batting or bowling. How does this happen? It is because he or she has been given a practical exposure, practical opportunities to bowl, bat, field, etc., keep the wickets, whatever it may be. Cricket is not learnt by watching television or by reading magazines or by reading books. One. Example number two. A person wishes to learn how to drive a car or a two-wheeler or four-wheeler, whatever the case may be. We'll take it as a four-wheeler. Initially, when he or she joins driving school, there is a period of simulation where in a simulator, subsequently, the trainer, the guide sits beside, and under strict supervision, the person is allowed to drive. Gradually, a little bit of supervised independence is given. Then a little more phased independence is given. And finally, the aspiring driver, the person who wants to learn driving, he or she is fully given independence, and then he or she passes the exam and obtains the license. Can car driving be learned by sitting at home by just? It is not possible. Therefore, applying the same examples to surgery, when a student joins the field of surgery, specialty or super specialty, as the case may be, there is a phase of passive assistance, then backbench practice, then assisted, active assisted, supervised surgery, and then quasi-independent, semi-independent chances, opportunities, and finally, when the performance is felt that it is adequate, then he or she is given independent chances to operate. This is how, through a graded, this is what is we call as a learning curve. So, through a graded training program, a surgeon is created. A surgeon, this is the way a surgeon is made. Now we come to the question. What is the status of training, practical training of surgery postgraduates and super specialty residents in India? Is there a graded surgical postgraduate specialty and super specialty program in India? What is the answer? There is only one word answer: pathetic. Another word: hopeless. Two-word answer: absolutely useless. I'm sorry, I'm being very candid, but that is the truth. Most of the colleges, if not all, there are some centers, as always, which are high volume centers, which are good centers. They take pride and they take interest in creating surgeons, in giving a beautiful training to the surgeons. I never say no, but in a majority of the institutes, colleges, or whatever it is, the level of training is very, very bad. What do you mean by that? That will be the question that will be asked to me. The answer is very simple. They are not giving chances, that's all. Consultants or lecturers, assistant professor, associate professor, professor, additional professor, faculty, whatever you may want to call them, they come, they operate, they do the case, the PG goes on assisting, and 3 years are over. The exam is over, takes a degree and comes out being an assistant. That's all. One or two stray surgeries here and there. In other words, there is no formalized, there is no formal structurized, I'm sorry, that is the word I was searching for. There is no structured program, there is no structured format. So before we go on to the remedial measures, let us just visit what is happening in the Western countries. We'll take two examples, United States of America and United Kingdom. You see, these are, we all know that these are so-called advanced nations, Western nations. We all look at them, look up to them, whatever you may want to call them. Why have they evolved? Why have they become what they are? It is not because they have invented some fighter jets or some SpaceX programs. That it is because they have a common sense based thought process. 1. 2. They have evolved a protocol. And 3. They have developed an administrative will to implement this protocol. These 3 things are very, very important. 1. Common sense based thought process. What do I mean by that? The Western world realized that surgery is a skill subject. They obviously realized that when they if they have to create a surgeon, that surgeon has to be trained. Once the surgeon is trained and comes out, where will he or she go? He or she will have to serve the United States of America or United Kingdom or whatever the case may be. So, if that particular surgeon is ill-trained, under-trained, sub-trained, whatever it may be, I'm sorry if some of the words grammatically are incorrect, what will he or she be? He or she will be a burden to the society. He or she is going to perform botched up operations. The patient is going to get stuck up. Mortality, morbidity, and it is going to be a financial burden on the nation itself. What is the solution? Train them perfectly and bring out trained surgeons. Let them serve the nation perfectly. Use them. Utilize them. Utilize their knowledge. Utilize their skill. How? By imparting knowledge and skill to them. In other words, these Western worlds evolved as a result of only one philosophy. The philosophy was to create a surgeon, not to create a personal assistant, not to create a personal secretary who just goes on taking down notes, writing the case history, writing case sheets, writing medicines, writing OT notes, writing discharge summaries. Our man or our lady, all the 3 years, this is what they do here in our nation. That is not the case there. They have a graded program. These surgeries, these number of surgeries will be done in the first year. These number of surgeries will be done in the second year. These number of surgeries in the third year. To go a step further, in the United States of America, during the surgical training program, and in the final year, the postgraduate is designated as Chief Surgical Registrar. Now, this is not an ornamental affectation or an ornamental or a cosmetic degree. A Chief Surgical Registrar is a person who, in the final year of his postgraduate, his or her postgraduate exam, is given complete in charge of the department. He or she virtually runs the department. In other words, they are creating leaders. What I want to impress upon the viewers is, look at how the system is. They give the department in charge. They put a responsibility on their shoulders. Once that responsibility comes onto them, that is how the transformation occurs in them, and that is how they come out. They come out as what? My classmate in general surgery went after completing cardiothoracic surgery in India, after having worked for 1 year in India, he went to the United States of America and completed a 7-year degree program, the higher degree program, beginning from general surgery down to cardiothoracic surgery. The moment he came out of the degree program, 7-year degree program, he was appointed as Director of Cardiothoracic Surgery. First appointment, very first day, Director of Cardiothoracic Surgery. In our nation, can you give me one example where a student comes out of either a surgical broad specialty or a super specialty and is given Director of Cardiothoracic Surgery? In other words, if that person a person, whoever it is, has been given director of cardiothoracic surgery, what is the amount of skill that he has imbibed, he has been imparted, and what is the confidence that the system and the nation has in him or her, as the case may be. And this is what we have to look at it. Second example, Royal College of Surgeons, the famous Royal College of Surgeons in the United Kingdom. I'll be brief and to the point. There is a very rigid system. Postgraduates are trained for FRCS, either specialty or broad specialty. There is an FRCS committee, the Royal College of Surgeons committee. It consists of examiners or whatever we may want to call them. They come every 6 months and interact with the students. Closed door session. Students are asked very specific questions. Are you being trained? Are you being given chances? Is this consultant giving you chances? If there are no chances that are being given, the consultant is pulled up. If still the consultant persists, he is pulled out, he or she. As simple as that. That is the reason why we all talk about FRCS. I mean, even an ordinary person, he or she may not know what is MBBS or MS or FRCS. Yes, they definitely know what is FRCS. Why? These are all time-honored training protocols. These are all time-honored degrees. And these nations have become, they are what they are. Why? Because of such things. They have not just dropped out of the sky. Therefore, keeping these two examples as a foundation, in India, what is it that we need to do what does medical education restructuring curriculum feel would be the best way or the strategy to impart surgical training to our specialty and super specialty postgraduates? It is there in front of your screens. 1. The creation of an common All India surgical logbook for every specialty and super specialty, which clearly defines and spells out in unambiguous terminology the various kinds of procedures that a specialty or super specialty PG has to perform, beginning from simple to the reasonably complex procedures. Second, rotation of postgraduates amongst the surgical units in the department at regular fixed intervals without stagnation in one unit. Stagnation leads to lack of exposure to different honors, different techniques from different surgeons. Also, in this same section, MERC feels that every postgraduate must be placed under the tutelage or supervision of a qualified consultant, be it a lecturer, assistant professor, associate professor, or professor year after year. And these must act as mentors or teachers who should be ultimately and directly responsible for ensuring that the PG completes at least a major portion of the laid down logbook. 3. To ensure that there is a proper, well-organized, well-defined, well-laid out internal assessment marking system for the postgraduates during the 3 years, which will ensure that they are disciplined, committed, sincere, hardworking, and meeting the required standards of academic intelligence. And lastly, the need, the most important. This is the first time we would be approaching this particular topic. We will elaborate on this later. MERC strongly feels that the time has come where there is a need for an apex body for the surgical and super specialties, which will ensure that all the above requirements from both the faculty and students are successfully met with. In other words, a supreme regulatory body that will oversee the process of successful implementation of the entire PG specialty and super specialty residency training program in India. This being the case, a small model of the logbook is going to be presented on your screens. I request the viewers to have a look. This is a very crude model. Please have a look at this. So, this being the model of the logbook, the viewers, I draw the attention of the viewers to this particular slide, which shows these abbreviations. A2 stands for second assistant, A1 stands for first assistant, OSS stands for operating surgeon under supervision, OSI stands for operating surgeon independent. Therefore, when a student completes a particular surgery, in the logbook there is a slot that is being given. There is a column where it will be very convenient for the student to write down, note down, wherein he or she has to mention whether it is he has or she has performed as a second assistant or a first assistant or a under supervision or independent surgeon. Therefore, when at the end of 3 years, when an inspectory body or an apex body, we will come to the apex body later, when an apex body scans through the logbook, if it finds only A2, it means that the student has been doing only working as a second assistant. That means far away from the table. If there is only A1 in the majority of the procedures, he or she has acted only an assistant. If there are some OSS, that means under supervision the student has performed, and it is reasonably good, not bad. And if there are quite a few number of OSI, that means operating surgeon independent, that means the training of this particular student is satisfactory in that he or she has done quite a number of independent surgeries. Having thus finished about the logbook, we now come briefly to the second segment, that is practical training. As already mentioned, I'll be brief and to the point. Practical training needs to be mentored. First year, preferably to be mentored by a lecturer or assistant professor. Second year postgraduate needs to be mentored by a assistant professor or associate professor. Third year, final year PG has to be mentored by an associate additional or a professor or the head of department. So this is about the practical training. The third is about the internal assessment marks. We will elaborate about the internal assessment marks. How will this internal assessment marking be implemented? 1. What is the use of this? Where will it be used? How will it be used how will it be useful for the faculty, and how it will be useful for the student? These are the questions that we need to answer. As of now, in our present system, internal assessment marking is only a formality. There is something known as internal assessment, but it is not being counted for the final examination anywhere across our nation. It is only just a formality, that's all. Having said that, on your screens, we are going to see a model of the internal assessment marking system that MERC would like to propose. The third most important factor, as we had just mentioned, are the faculty. It is the faculty who make or break the training program. There is no ambiguity about this. At the end of the day, they are the people who either give the surgical opportunities, surgical chances, graded surgical training, either they give or they don't give. If they give, the student will come out as a reasonably trained surgeon. If they don't give opportunities, the student is just going to come out as an observer. That's all. He or she would have observed the surgeries, assisted the surgeries, but he or she would not have gained any first hands-on experience, as it is technically known as. It's technically known as hands-on experience. Now, regarding the faculty, you see, I don't think that this is the podium or this is the platform to discuss anything that is controversial. I will not get into any frictional debates. I can only say one thing, that when it comes to corporate hospital, the corporate consultant perhaps is not under an obligation to give any chances to anybody, because in the sense that I'm not talking about students, I'm talking about some assistant or whatever it is, because they are all corporate, they are paid cases, they are all private cases. There is a huge responsibility and a huge stress upon the consultant, private consultant, corporate consultant, to perform. Mistakes are not tolerated, mistakes are not forgiven. So it is understandable. But when it comes to institutes, teaching institutes, government institutes, or whatever you may call the institute, where a student is, to put it in a way, invited to join the post-graduation course, surgical specialty or super specialty as the case may be. Once having done so, it must be remembered that they are designated not as consultants but are faculty. That means they are given the sobriquet of lecturer, assistant professor, associate professor, professor. Means what? That means they are meant to profess surgery. They are meant to impart the training. That is the reason why they have been primarily appointed. Otherwise, there is no difference between a government institute and a corporate institute. If in a government institute, if a consultant comes, operates and goes and says whether I don't know who you are, I don't care whether you are a student, whether you learn or not, then what is the difference between a teaching institute and a corporate hospital? I will not go into any other frictional areas. Government institutes, teaching institutes are meant to give graded surgical training to PGs, and it is the onus is on the faculty. So, point about an apex body. In India, do we have an apex body like the Royal College of Surgeons, as I had just mentioned some time ago, like the PG coordinators, program coordinators in the United States of America? Do we have a dedicated apex body which can ensure that there is a graded, perfect surgical training for the postgraduate specialty / super specialty? No, there is no apex body at all. So, do we have an apex body that can stand and get the logbook implemented? No. Do we have an apex body that can address the grievances of the postgraduates directly? No. Do we have an apex body that can come and interact with the students and the faculty alike and address whatever are the grievances, problems, etc.? No. Do we have an apex body which can interact with the directors of the institutes or the heads of the institutes and ensure in toto that there is a successful postgraduate specialty and super specialty training program going on successfully? Do we have an apex body at all? The answer is no. So, this being the case, before we go further, we have just spoken about logbook, we have spoken about faculty, mentors. The viewers, especially the postgraduates, a vast majority of them would like to ask me a very simple, crude, direct question. The question is, no matter what logbook there may be or there may not be, no matter what apex body there may be or there may not be, at the end of the day, if a particular faculty or faculties say that they are not going to give surgical chances or opportunities to the PG, what can the PG do? What will the apex body do? This, I'm sorry, is a very confrontational question, but this is the raw truth. This is the truth. At the end of the day, if a particular faculty says, no, I'm sorry, I cannot give you any chances, you finish your course, you go outside, and then you can learn, practice in a high volume institute, and you please make your future. What happens then? How do we unlock? How do we address this problem? You see, MERC is proposing this idea of an apex body. For an apex body to take some kind of a positive practical steps, it needs undoubtedly a feedback from the PGs. Upon, let us say, a 6-monthly interaction with the PGs, if the PGs say, or if the PGs do not volunteer to say anything, then this entire thing collapses. The question here is, why are PGs unable to even venture to go and ask the faculty that they have to be given some amount of reasonable amount of surgical chances plus or minus the logbook. What is that single primordial factor that prevents the PGs from even venturing about this? Forget the apex body for the time being. What is it? There are two reasons. Reason number one, when a post-MBBS graduate joins the PG course, the typical scenario is as follows. He or she enters the college, meets the head of department says, go and meet associate professor busy in the OT, go and meet assistant professor in the OPD, go and meet lecturer is busy taking rounds, okay, you go and sit with the senior PG will take care of you. So senior PG is seeing a pile of files in the OPD. So he says, hi, who are you? I've just joined. Please come start seeing the files. No introduction, no this thing, no that. I'm not saying that there is no orientation program. I'm just telling you a scenario. So after the OPD is over, after lunch is over, after afternoon rounds are over, somewhere in the evening, the postgraduate, the senior most postgraduate and the newly joined postgraduate, young postgraduate, they both sit together in the duty room. 2 beds are there, coffee. So a man asks, where are you from? So he says, I am from such and such a college, I just joined. So the young PG, the first year graduate, full of excitement and full of zest and zeal. He asks, sir, chief, what cases have you done? You're getting chances, getting a lot of chances. So a senior PG full of worldly wisdom, he now begins the process of indoctrination, as I would like to call, to this junior PG. He tells our PG, see, you have joined a PG surgical course, whatever it may be. This is a 3-year journey, a small journey, a tiny journey in the part of your life. Your life is very long, your professional life, 30 years, 40 years, 50 years. In that, this is a very tiny period. What is the primary aim of this 3 years? There is only one aim, remember. Keep quiet. Don't open your mouth. Don't act smart. Don't go around jumping around saying, when am I going to cooperate? When am I going to get surgical chances? Shut your mouth. Behave well. Say yes to everything. Don't rub on the wrong sides. And pass your exam, get your degree, get out. Once you are out, afterwards you need not even turn and look back and even say good morning to our so-called, with due respects, whoever it is. I leave it to the viewers of the imagination of the viewers. Once you get your degree and go out, you have the rest of your life to pick up your skills to become a surgeon, super surgeon, whatever it is. But you try to act smart and you are going to stay here for more than 3 years. And how long more than 3 years? I leave it to your fertile imagination. Therefore, my friend, the aim of this PG course is just float through, just sail through, smooth, no controversies, no friction. Pass your exams, take your degree, get out. Because the sorrow of not getting surgical chances or whatever it is very, very small, very, tiny compared to the sorrow of failing in the final examination. You act smart. You go around demanding surgical chances, you go around complaining here, they're saying, I'm not getting that, this and all. They will give you all the surgical chances and finally fail you in the examination. What will you do? You will have that permanent seal on your report card or whatever it is, passed in second attempt. It will be a blotch. Therefore, in this manner, on the very first day, first show, as they say, opening show, 5 o'clock to 6 o'clock in the evening, our man senior PG would have brainwashed and indoctrinated the young PG, and then the first year PG will come out with all the, he will come out with that knowledge. He'll come out with that, that complete perspective and then he will toe the line. Therefore, why this point was put across is that fear of failing in the examination, in the final exit examination of a postgraduate specialty or super specialty, is the single primordial factor which hangs like a Damocles sword over the neck of the PGs. It is this fear because of which no PG will ever dare to complain, no matter whether they're an apex body or no matter whether whoever it is, even if the health minister or, with due respect, the prime minister himself can come and have an interaction. Nobody is going to volunteer anything because the health minister or the prime minister is not going to give the degree. They are not going to sit in the final examination. The final examination, HOD will be sitting. And now man speaks something against the HOD or says that this is the end of the story. Fear of failing in the final exit examination is the single most primordial factor which will continue to prevent the successful implementation of a well-structured postgraduate program, apex body or otherwise, logbook or otherwise, faculty or otherwise. Having thus explained in detail what are the factors to ensure that all this happens, MERC proposes that there is an apex body. This is also very fine and very nice and sweet to look at, very ideal. But in reality, I have already just told you what the reality is. Final question regarding the ultimate remedial measure to ensure that there is a 100% strong, honest, well-structured surgical training in India. What is the final solution that medical education restructuring curriculum proposes? The conduct of the final exit examination of every specialty and super specialty, medicine, surgery or otherwise, every specialty and super specialty degree courses must have an exit examination that is conducted by all 4 external examiners with no internal examiners. Once there is no internal examiner, the question of this, when are you going to take your exams? Do you think you will pass? All these kind of things are going to be tossed out of the window. Students will be facing an all 4 external panel. He or she is going to pass this exam based on their own merit, their own mettle, their own knowledge, their own performance. This fear of will be totally wiped out. 4 external examiners on the day of examination. Present your case and you are passed. This in turn, this system will have multiple ramifications, positive ramifications. An apex body, if the government, as I always say, I repeat and repeat and repeat, if these proposals are accepted in the government and if the government finds it, and if the senior faculties all over the nation, if they find that there really has to be an apex body, then the apex body can interact and intervene and ensure and make sure that the implementation of the surgical PG program, training program takes place effectively. How? Because now that the fear of failing is gone, students with great amount of transparency can interact with the apex body. They can put forth their grievances, whatever they may be, and the apex body can interact in turn with the faculty and make sure that things are straightened out. The removal of fear of failing in the examination is the single most factor, and that is achieved by, I repeat, removal of the so-called internal examiners completely. All 4 external examiners, immediately there will be a question from the faculty, from the viewers. It is not just from the viewers and faculty, this is a question from myself, because I myself, I have been working as an associate professor of cardiothoracic surgery, and the question, even before the viewers would like to ask, I myself would like to put forth this question. The PGs will become, with due respect, they will become rogue PGs. Why? Because now they are going to say, we have our professor and head of department is not going to be the examiner. So I need not respect our man. The apex body is there, they will come. When they come once in 6 months, I am going to tell them that they are not giving me chances. On one hand, I am going to take chances because it is my birthright. On the other hand, I will not respect the head of department because he is or she is not going to be the internal examiner. You are going to make devils out of the PGs. This is what will happen. This is the doubt this is the question that viewers would like to ask. I agree to that. Notoriety is their middle name. Right from inter-unit politics, intra-unit politics, internal politics, external politics, down to not working, lazing around, enjoying, wanting only to cut and go away, grabbing surgical chances, maneuvering, telling stories from here to there. Yes, we have seen all this. At this age of 54 years, I have seen all this. So it is not the case that MERC wishes to create notorious characters out of PGs by introducing just this system. There has to be an introduction of a internal assessment marking system, which will be countable, which will be included as a part of the final exit examination marks. In other words, 30%, 35% or 40% of it marks will be from the internal assessment marks, which will be made by the professors, head of departments, faculty, lecturers, assistant professors, etc. based on the performance of the student over the 3 years. And 70%, 65% or 60% will be from the final examination, that is final theory and final practical. So now what happens? Now there is a balance. What do I mean by that? 30 to 35 or 40% as what is deemed correct will be in the hands of the professors, head of departments, faculty. The PGs, they cannot act smart. In this 40% internal examination marks or 30%, if they try to act smart, if they try to be disobedient, if they try to think that they can get away by not working, they will be given 0 out of whatever percentage. So what happens? They will land up in the final examination. In the final examination, there will be 4 external examiners and there will be 70% marks at stake or 65%, whatever it may be. The PGs have to score 60 out of 60, 100% they have to get it right in order to pass the examination without the help of internal assessment marks. One little mistake, one small mistake, one tiny mistake, one minor mistake in the external examination, and they are going to flop, they are going to fail. The internal assessment marks in such a situation will provide as a support to passing if they have been good, obedient, hardworking and diligent. If they have played the fool, they will be marked 0 or 5 or 10 out of whatever the marks, and totaled together they will not clear the 50% barrier. Therefore, on your screens is the summary of the final summary of advantages of introducing the system. I request the viewers to please have a look. Final exit examination to be conducted with 4 external examiners along with internal assessment marks. Postgraduates will be eliminated from the clutches of fear of failure forever. Faculty will be under no obligation to pass any students. They will be relieved of the headache to having to pull or push any student. Faculty would be connected only and focused only on making the PGs into efficient surgeons by giving them the deserved graded supervised surgical opportunities according to their hard work and efficiency. Students will be all the more disciplined and hardworking because now they will have to pass the exam on their own merit and strength. Professor will not be sitting and trying to help them or push them. Students will now be in a position to interact positively and fearlessly with the apex body. At the same time, the fact that the apex body also would be in turn able to monitor the program in an unhindered manner. The fact that 30 to 40% of the marks would be designated as internal assessment marks and would be in the hands of the faculty will act as a deterrent and ensures that the PG does not become a rebel and begins to behave in an insubordinate manner to the respected faculty, because the final practical examination along with theory and practical would amount only to 60% or 70%. The rest of it is internal assessment marks. So the PG has to be respectful, has to be obedient, has to be hardworking, has to be efficient. Therefore, the honorable faculty will continue to have a firm disciplinary hold on the postgraduates. They cannot run amok, AMOK. At the same time, the honorable faculty would do well to give the stipulated number of surgical opportunities to the postgraduate, train them adequately, and send them out as efficient surgeons, for which the students also would be eternally grateful. The students in turn, as a result of the system, would be on their toes 24/7 into 365 days, studying, learning, case presentation, advanced techniques, operative techniques, theatre, ward rounds, bedside, clinics, ICU, because now the postgraduates, along with being liberated from the fear factor of failure, would be facing a two-front war. On one hand, they have the daunting task of passing the exam on their own merit, and at the same time, they would have to score the maximum in internal assessment marks. Therefore, the final summary card of postgraduate specialty training: creation of common all India logbook, compulsory rotation of PGs every 6 months through multiple surgical units if present, allocation of faculty members as mentors, interaction of apex body members with faculty and postgraduates alike, discrimination, deficiencies and discrepancies to be addressed and corrective action to be taken, allocation of 30 to 40% marks via internal assessment, and final exam to be conducted by a 4-member all 4 external examiner panel.